That's the first part of the next issue that I would like to share with you. Maybe I'm not sure that this one gonna be in your consideration or your interest or not. But to me, when I first part of my practice, I do a lot of surgery. When in 2008, I moved from the government to the private. My practice way have been changed a lot because of in one case I have to spend at least 15 or 20 minutes or 30 minutes per one case. So one day I have the patient that have the Epiphora after the successful surgery. But at that moment, 10 years ago, I had no concept. I don't know how to explain to the patient why you have the tearing again after the successful endoscopic DCR. This one gonna be happen in every kind of the eye surgery. You may have the cataract surgery, you have the eyelid surgery, and cosmetic surgery, and you have the glaucoma or retinal surgery, and the patient have the tearing immediately after or 1 week after the surgery, because every kind of the surgery disturb eye surgery, disturb the ocular surface this balance. So I want to focus, I want to encourage you to focus on the meibomian gland, because 20 years ago we know about the meibomian gland, but we did not talk about this one so much. But nowadays, the concept after 2015, after the DUCE 1 and DUCE 2 are launched in 2015 and 17, the concept have changed a lot. So in the old day, I focus only the lens, the cornea, and the lid outside, not inside. So when nowadays, when I flip the eyelid, when like this, oh, in the old day we saw only one chic acid, just pull it out and burn it, that's all. But actually the patient have the chronic dry eye, they have the chronic tearing off and on. I think the problem of the meibomian gland dysfunction gonna be much more difficult than the surgery, because when we do the surgery, only 1 hour, half an hour we finish. But when we deal with the patient with the chronic meibomian gland dysfunction or posterior blepharitis or anterior blepharitis, that can be a long-term or lifetime treatment, and it can be very difficult. If you have the patient come in your office with the patient or with the problem of the tearing and entropy like that, actually do the surgery is simple, very simple. You can do this one, put tarsal rotation, tarsal fracture, entropy correction. After that, the dry eye will get better. Do you know why it's better? When you do the posterior tarsal fracture or total tarsal rotation, why the dry eye getting better? You know, any idea? Because we cut about 1 millimeter on the contraction area. When we make the full thickness, horizontal cut of the full thickness of the tarsal plate, the internal obstructed meibum have been released. So the next day the patient will feel much improved, and the obstructed meibomian gland that blocked for years and make the congestion, make the chronic obstruction and inflammation, the pressure inside intraductal gland have been released. The intraductal pressure reduced, so the patient feel relief. And when the meibum come out, the tear film is better. So the dry eye is dramatically improvement in the next day. That I have found 10 years ago. So I start to focus in meibomian gland dysfunction after 2008. You know, when one day I was in India, I was in the lecture in Hyderabad. I asked the audience about 200, that's about 10 years ago. About the audience, about 200 people. How many surgeons, how many doctors that fit the eyelid inside out, check in every case in your daily check? Only 2 persons in the room, because of the meibomian gland dysfunction had not been well recognized and well concerned. So the concept nowadays that I use in my practice is, now I consider blepharitis as the anti-aging treatment, because the normal like this, when the MGD like this, entropian, cicatricial like this, we want to make it like that. It's very difficult and very consume time and very expensive also. This is a healthy gland. This is a moderate MGD, and this is a severe MGD. I do encourage every surgeon to focus on the endopian and into the meibomian gland dysfunction. But the bad part is when you focus in this one, you have to talk about 15 minutes or 20 minutes more. You can consume your time a lot and you will fatigue a lot. But the benefit gonna get to the patient. But another benefit, the patient will not blame us. If we do the eyelid cosmetic surgery in the patient with a severe dry eye, the next week they complain about, oh, I got the more dry eye, I got the more tearing. The surgical result is so good, but I feel very bad, uncomfortable eye. But we have no answer. But if we inform them about that you already have the MGD, you have to treat this one after eyelid surgery, that's gonna be fine. But if we did not talk, everything come up, it's gonna be like complication from the surgery. This concept have been noticed me 10 years ago because this lady, she got the anal duct obstruction. We do both sides and we got the very successful. And after 1 or 2 weeks, she used a lot of reading computer and she got a lot of tearing. In the old day, we call this one pseudo Epiphora, right? If we search in the article 10 years ago, they talk about retubing, reintubation, do lid tightening, or do anything that, but not focus in the original cord. In this lady, if you take a look, it seems the whole cornea is look fine. But if you focus into the buffy filter, you can see the micro keratitis over here in the bulbar conjunctiva, in the exposure zone, and they have mild degree of the conjunctival callosis, and about 10%, 15% of the keratitis on the infromedial of the cornea. This is initiate ocular surface inflammation, initiate reflex tearing, initiate epiphora, initiate ocular surface inflammation. That's why the patient complain a lot. So when we flip the eyelid inside out, you can see that in this lady, she has a really bad meibomian gland dysfunction. She had 90% of the meibomian gland loss, even though she only 40 years old. That's going to be the tough one. When we take a look to the meibomian gland dysfunction, this is the how it happened. Because this is the normal gland, we have the red eye, inflamed eye, irritation of an grittiness in your eye. Normal tear film has the 3 layers, and the yellow layer is the outer layer of the lipid layer from the tear film. Once you have the abnormal vessel encroaching, they have the abnormal inflammatory cell, cytokine, interleukin, and initiate the obstruction. It's going to be like the vicious cycle. Initiate the dry eye, and that one initiate the irritation and reflex tearing. That's a mechanism of the problem. If you search in the PubMed, nowadays you search about the IPL and the Epiphora, you can see a lot of paper talk about this one. So my experience, I start to thank you for this is a tree of my mentor that pushed me in this one, because personally I have the really bad dry eye also, and I've treated myself for 10 years with the drop and the oral doxycycline, but nothing helped. Now I suffer for nearly 15 years since I am 32 and with no improvement. And after 2018, Rolando Toyos, he's a genius US doctor. He worked in Tennessee, and who the first person who found the IPL that could be treated for the dry eye. And this is the Laura Perrin. She practiced in both of them is a doctor in private practice. He's a refractive specialist, and she is a refractive specialist. Both of them focus in the IPL and focus in the meibomian gland dysfunction. Laura Perrin taught me how to perform the IPL in 2018. And thank you, Dr. Arita. She is a Japanese doctor. Tommy know her. And she queen of the MGD in Japan and in the world also. She discovered and described about the myelopathy, and we learned about from her study. And combination for all together, I gonna tell you my concept. If you focus, if you are the beginner or general ophthalmologist, you could not forget this one. Please apply the 4 steps of the treatment in all of your patients with the dry eye, because if you are any surgeon, you're gonna need to encounter with the dry eye. Step 1 and step 2 is very important. If you take a look in the IPL and meiboom expression, it's including in the step 2 of the guideline. So this is a very important and very practical. And I show you the evolution of the IPL. I think nowadays the IPL in Thailand is not that so popular. I think 3%, not that more than 5% of the doctor that interested in the IPL. But I have heard that in Japan it's very popular, like Tommy. I have heard that in 2019, I heard that in Japan they sell the machine about 50, and in Thailand it was only one. Mine is the first one in the country. But last year in October I was in US. I asked about the company how much in US. 1,000 machine have been sold. In Thailand only 4. 2 is mine. And this is the Rolando Toyo. Rolando Toyo talked in his lecture one day. If you need to be the best eye surgeon, you need to treat dry eye. That I do agree with him, because in the old day when I was the first part of my practice, I did a lot of surgery. I focus nothing about the dry eye. When I do surgery, I let the patient go. When they come back and complain about dryness, I say nothing. I just put the drop and steroid, and they use better about 2 weeks and then come back again. And the patient did not come back because they go to another doctor. That's the problem. And we're gonna be I maybe talk badly by the patient or by the previous other doctor. So I totally do agree. If you want to be the best cataract surgeon, you need to treat dry eye. If you want to be the best eyelid surgeon, and we are oculoplastic, we are eyelid surgeon, we are eyelid man. So I think for myself, I need to know everything outside the eyelid. I need to know everything inside the eyelid. If the patient asks me about the eyelid, I have to have the ability to tell them everything about the eyelid. So ocular surface including more than 50% of the eyelid. So I think this one gonna be very important. So I spend a lot of time with the IPL. This is the first paper. I would tell you about the story. This is a genius doctor. Rolando Toyo discovered the IPL, and he published in his clinic website in 2005. In that moment, he used the first generation of the IPL. Why he published this one? He used the setting that he used for the cosmetic. If you are the cosmetic or the dermatologist, you're going to see the patient with the rosacea, red face a lot. He used this setting for the patient with the rosacea, and he do the treatment for the patient with the rosacea in his office, because he is a refractive surgeon. His wife is an oculoplastic. They have the private clinic together. They bring the patient for cosmetic for do this one, but he is genius enough to recognize that one day the patient told him that, after IPL, her dry eye is better. So he think about that. He come back and take a look and reconsidering and figure out and try and error for another 10 years. So he published that they have some improvement in the first generation in 2001. So he published in 2005, and this was 20% improved. He did not stop. He continued search about the protocol, about the setting, about the way to do that. 60 to 70% of the dry eye markedly improved it in 2007. And in 1997, big improvement. So after 2017, the company get the new machine and have been sold. So the eye doctor around the world use the IPL for the dry eye. So this is the group of the pioneer in the US. So if you search about the article, especially in 2003, you're gonna see 125 paper talk about IPL and dry eye, IPL and MGD. When you learn this one, when you focus this one, I encourage you to focus on this one because it's very fun. When you read about the paper and you try about the treatment, you see the improvement, you something like learn by your own. You learn a lot from this one. I'm gonna let you know about how IPL work. I think nowadays it's pretty new for our ophthalmology society. Even though last few months I talked in the ISDDE of the Society of the Dry Eye in Singapore, and a few doctors interested in the IPL. Two of us, one is mine and another is Jane Oliver in UK. She started to do the IPL also. So we mail each other, and we do agree that this one helped a lot. So I think in US, the oculoplastic surgeon started to get use this one in their practice. So the concept of dry eye, all of this one you can read and learn by yourself. But I would say that the dry eye is a process of the inflammation. It's a vicious cycle. Rosacea, demodec, refractive surgery, unstable tear film, MGD, eyelid inflammation, abnormal blood vessel on the lid margin, all provoke the ocular surface inflammation. So the concept I gonna tell you in briefly and easy, because they use a concept of the light. When you use the light, not the laser, the light have the spectrum about 400 to 1200, that this one. And they use a concept that we put the light to the target. But how deep that we need the light to affect to the organ depend on the filter that we put. When we selected the filter, appropriate filter, to put the filter in front of the light, they block the light above suppose we put the light 590 and the light above 590 can go to the tissue. The tissue is called different depth and the chromophore. This is the target organ. And the light from the machine photocoagulate the abnormal vessel on the lid margin. As example, if you have the severe MGD, they coagulate the blood vessel, and the light have the specific figure that not damage to the tissue. And if you use a low wavelength, it go very shallow, like skin dermatology use. If you use more wavelength, it can go deeper, like the retinal use that one. So the Luminis is one machine that I have used, and they call the Optima IPL. Comparing to the old concept and the new concept. The old concept, the light come in one pulse, and the new concept they separate to be 3 pulse in one boom. They come boop boop boop. So they have the lag period. So they divide the energy. So the power is same, but the collateral damage is none. So it's very safety. And this is a patient that have the rosacea. This is why I talk that I tell you that initially they discovered that they put the IPL and the rosacea getting much better, and the dry eye also better, because sebaceous gland is the same family with the meibomian gland. They create the meibum. Once they block the abnormal blood vessel, inflammatory cell have been blocked, so the tissue is come back to normal. This is very new concept for the anti-aging. So 80% of the rosacea, they have the dry eye. This is in my office. In the past 3 years, my practice have been changed a lot. I not intentionally to focus or want to do the IPL, but when I was the first person in the country to do this one, When we do one patient, we have big improvement. I have many cases that the patient have got the very bad tearing, very bad dry eye, very bad irritation, and the patient have seen 10 ophthalmologists but no improvement. When the patient come to me, I explain to them about the concept about how bad you are, and you got the IPL, you get better. When we do, it's a promising result. It's an expecting result. So that's why we have a lot. We do about one day, 15 cases per day at least, until I cannot, too much for me to do that because a lot of patients. And I think in the next 5 or 10 years, maybe every ophthalmologist will concern on this point. And this is just a paper that talk about in 2016, they do the study about 4 times of the IPL and evaluate the efficacy of the IPL. They do 4 times. And you know the lid margin edema better, facial telangiectasia better, lid margin vascularity better, meibomian viscosity better, and the OSDI score is better. And this is decrease is improving, and oil flow score is increased and tear back up time increased. This all have been proved by many studies. This is study about improvement after the IPL for the tear back up time. So this is a simple concept that improve. One thing, if we are the eyelid surgeon, one thing that I think we should not neglect because it's about the Demodex. When I was a resident in 2002 or 2001, we heard about the Demodex. Someone talked about the Demodex, but we did not think this one is important. But nowadays it's very important because of the Demodex. For the incident, if you are 100% of the patient in the general population, you know how many percent that in this patient you 10%, 100%, how many percent that we gonna find the Demodex by examination by the microscopy? Can you guess? 54%. We are 10 people, 5 of us, 5.4 of us gonna have the Demodex. If you are above 60 years old, you can have 70%. You're gonna find the Demodex. If you above 70%, how many percent you guess? 95% that you go. But this one gonna destroy the gland. Let me show you. This is the direct slit lamp photography. If you have no slit microscope in your office, no worry. You just open the video mode and you put the eyelid super dry, not wet, and you put your elbow stable to the table of the slit lamp and grab gradually and pull it out and rotate 360 degrees and pull up. You can simply show the patient that you have Demodex. But if you not enough, you want to put more awareness, you just focus at them and let the patient head back and use the shadow to be the background, and you put the slit lamp in the 45 degree and you can see the Demodex. Sometimes you can see with the good slit lamp, you can see the leg and the tails, but not the egg inside. But you can see the mouth from this one. But if you want to put more awareness to the patient, this is the way that we show the patient. You can see in this patient, they have the really severe meibomian gland dysfunction. They have the severe dry eye. If you put the electron microscope, this is the hair follicle, hair chop. This is the Demodex. Sometimes you found 25 body per eyelashes. Sometimes you found 3, 7, something like that. If you have dry eye, you have more than 54% that you have the possibility to have this one. But some patients they have symptomatic. Some patients they have non-symptomatic. But all of us, 100% hygiene, right? If I tell you that you have your eyelash have 5 body of the Demodex, you're gonna be worried? Yes, all right. The treatment is ready. In the old day, they talk about baby shampoo, right? In 2015, they talk about oral ivermectin and oral metronidazole. This is the Demodex. They have two type of them. One of the follicularum and one of the brevis. This is more common. They live inside the hair follicle. They lay the egg in the night time. When you wake up in the night time and you feel itching, that's the Demodex come out and mate each other, and they come back and they have one mouth, no anus. They eat and they ingest inside and they put the feces from the mouth, and their body, they live in 3 weeks and die, and they live in the hair follicle. So this is the egg inside. Inside the body, the Demodex, they have bacteria. Bacillus oreillonium is a co-pathogen. So that's why the patient, they have the Demodex, they have the inflammation, because all of us was born with the super good eyelid. When we born, the eyelid is 100%. The patient always ask us that why we have that, why I have the Demodex, I so clean. I would tell them, make in short, you clean your hair every day, right? You clean your axilla every day, right? Have you ever cleaned your eyelid every day? Most of them say none. That's why the patient have the Demodex. So the step is going to be the normal, dirty, biofilm, like toxic free fatty acid from the lipid and the dirty lipid. And the bacteria come, step, and until the blepharitis happen. And then Demodex come. That's the way it is. So that's why they develop. This is a patient after the microscopic eyelid hygiene in my office. I let sometimes myself, sometimes I let train the nurse to be the nurse eyelid hygiene specialist. Because 10 years ago I do by myself because no one pay attention that one. 10 years ago, I cannot because my job is too much. I train my nurse to be the nurse eyelid hygiene specialist. And after examination, I tell the nurse to use a microscope like Tommy did the surgery and clean. You see, immediately after microscopic cleaning, I will show you after immediately cleaning, you use the same pulling technique, good for safe, dry eyelid margin, you pull it out. You can see the Demodex inside. That's why the Demodex, why it's so stubborn, why it's so difficult for treatment. Because if you do not pull it out, you not show the patient with the microscope, they that recognize this one, they not know how important it is, and we leave the pathogen inside the eyelid. That's why I think it's so worthwhile for us to think about inside the eyelid, to treat about the cellular level more than the surgical that we will practically routinely do that one. You see, this is the eyelid that's so inflamed and dirty. If we do the surgery for the blepharoplasty and neglect for this one, it will be very easy. I see the patient, do the blepharoplasty and you go. And after the surgery, if you don't have tearing, no dryness, that's fine. Just simple eye drop and artificial tear. But the patient will suffer this one for years. They miss the good opportunity to have the normal eyelid, because the eyelid is very important and the hygiene and the meibomian gland is very important. This is a treatment. This is a concept. This is a severe meibomian gland that have all bacteria and Demodex. You see, this is a mucocutaneous junction. This is a meibomian orifice. This is a posterior rounding of the eyelid margin because of severe 10 year, 20 year, 30 year, 40 year of the chronic inflammation. After 2 times, you see what the difference. You can see the size of the abnormal blood vessel is smaller and further, and all bacteria gone because the light from the IPL killed the Demodex. But not that enough. You need to clean properly. And if you leave, this is the paper that talk about the ivermectin and or metronidazole. The paper said that if you do this one for 2 weeks, they kill the bacteria about 72.4%. But this is all day. That is 5 years ago. This is the primary treatment 5 years, 10 years, 7 years ago. And some people talk about tea tree oil with the foam, with the bed egg for cleaning. This is the good one, but they treat at the final result. They clean up, but not treat at the cellular level. And okay. And this is a paper that talk about how the Demodex IPL eradicate the Demodex. This is a good paper from China. I think in Thailand we 5 years slower than US, Japan, and China. In China, a lot of good paper published about this one. In Japan also, I don't know, but sometimes I may talk to you. You may know better than me. I'm sorry about that, but I would like to share my experience. But this is a good paper that they talk about the IPL can help the kill the Demodex and eradicate. Very good. And this is a good paper from China also. And China and US, they collaborate together and they do the IPL boom, boom, boom. And they put the Demodex in the slide and do show about the movement. It show that slower movement, not die immediately. But the Demodex have the leg movement slower. This show that something like you got burned. You get like a very hot burn. So it like dead, like you got the bomb, but you don't die immediately. But we could not make the Demodex die immediately because we need to use a really, really strong power. If we use too strong power and put to the upper eyelid and put to the lower eyelid without protection, what's gonna happen? The pupil will get distorted. The pigment in the iris will be faded. And photosensitivity gonna happen, and that's gonna be the permanent damage. This is to show the real-time study that about the movement of the Demodex gonna be slower by the paper. This is a good paper. And eyelid margin size. This is very important. I want to show you about the 2 times of the IPL. They have the orifice have been better, and the MC junction could be if you have this one. And retrograde of the MC junction, the radiate all gone. This is the clinical side that we use to follow up, and we use to tell the patient why you need to go further for the treatment. And this is not a short treatment; it's a long-term treatment. And this is after 9 times of the treatment, and the clinical gonna improve significantly. But the clinical side of the eyelid side may be slower, but it's gonna be the way that we use to inform the patient when we flip the eyelid, take the good photography and show them before and after, so the patient know, oh, they have the improvement. And 9 times, and this is 15 times. This is a Thai lady, 75 years old, very severe dry eye, and ectopian from the previous plastic surgeon that did the really bad cut the skin too much. And she denied for the eyelid reconstruction. She denied, but she had the really bad dry eye also. She suffered for the chronic dry eye all day, all night for 20 years. So she came to me, she denied for the eyelid. So I put the drop, and I tell her you should get the IPL. So she did agree, and she did about 15 times. She had been improved so much. After that, she happy. She fly back to US and live in US for 9 months without nothing, without repeat of the IPL. And we eat the my boom expression. What happened? The problem come back again. So she had to fly back to Thailand to see me again from US and get the continuous treatment. By that moment, it's 21 times. But nowadays, she got 26 times. But I would tell you that this is a very, very difficult treatment and not simply like we did the surgery. So if we do the microstructure about the meibomian morphology and functionality, the IPL would help. This is a good paper from China again. You see, in each world, they did a very good paper. You see, this is the acinas have been better. MG orifice is better. Fibrosis decreased, and Demodex in the lab better in 2 patients. They do the study in the confocal microscopy. Every sign of the improvement after this one have been proved already. And meibomian gland expressibility. This is another important factor because when you do the meibomian gland alone, it's not that enough. IPL alone is not that enough. Due to guideline after IPL, you should do meibum expression. That's why when I do the patient with the entropion, especially in the kid, sometimes if you evaluate the kid that have the significant entropion, if you do the meibum expression on the patient with the entropion in kid or adult, you're gonna see a very bad turbid meibum. When you cut in the posterior lid margin like the tarsal fracture and you do meibum expression, you see not the clear meibum. You can see the very bad turbid meibum. And if you express the meibomian gland, the eyelid margin size will get better. So that's the way that I always do. This is my lip view. This is my gland. You see, my gland have been lost about 50%. This on left side is 60%. I have a really bad dry eye on left side more than on the right side for 15 years, very bad. And the lower lid have been lost about 40%. And the orifice is all blocked. But I did not recognize this one, even though I am the ophthalmologist, Some ophthalmologists have never done meibography before, have not know how bad you have dry eye. Sometimes it's what a shame that some of my colleagues is an ophthalmologist. She came to me and got the examination. She had 20 mites in one eyelashes. She is a glaucoma specialist. And she practiced for 10 years, that's what a shame that we did not recognize this one. And so this is a really bad my lip view. Normally when you do the lip view, we check the lipid layer thickness, right? Normally lipid layer thickness is 100. Below 60 is bad. Below 40 is super bad. Initially I got only 36 and 46. When I got the IPL, I improved about 54 and 67. But this shows the improvement. But in every patient, not going to be like that because the dry eye is a multi-factor. Sometimes you do the surgery 10 cases a day like Tommy. Sometimes you work computer 8 hours a day. You come back home and use a smartphone or another 4 hours and you have allergy, something like that. They have many factors for this one. This is my own gland. Before the dry eye, before the IPL, you see my gland is so turbid and so difficulty and have the very bad telangiectasia on the lid margin. And it's very difficult to express this one. This is my gland after 6 times of the IPL. You can see that my gland improved a little bit for the redness and expressibility is improved a lot. It's not that turbid like previously. This is the mechanism why you have the chalasia. This is the mechanism why you have the chronic hordeolum. Some people they have hordeolum 10 times a year, 6 times a year because this problem. If we treat the IPL with the patient that have the chronic hordeolum, they're gonna never have this one again. If we treat properly about the bacteria, the dermatitis, and the meibomian gland and do expression, warm compression alone is not that enough. So we need more weapon. So this is show after 6 times. I gonna show you, this is after my 28th time of the IPL. This is a lot of time to do that, but this is in 4 years. But I may be the only person that did most IPL time in the world. I'm not sure, but right now I got 32 times without side effect. But in the literature that I couldn't show you that why I so dare enough to do the IPL more than that, because many ophthalmologists in Thailand not want to start this when they afraid about the side effect. They're afraid about the retina. They're afraid about the cataract. They're afraid about the side effect. Okay, improvement of ocular surface staining and conjunctival callosis. This one have not been published yet, but this one happened to my eye. Corneal stain. This is one lady, 80 years old, she got a really bad dry eye, red eye all the time for 20 years. She came to me, she got the cataract surgery. After the very good 2020 cataract surgery, she complained about a lot of irritation after cataract surgery from my colleague. But she blamed a lot of this one to my colleague. But my colleague did not recognize this one. But this is a dry eye. That you can see the dry spot a lot, and you see the conjunctival callosis a lot. And the patient denied to get the conjunctival surgery. She denied to do the conjunctival resection or conjunctivalplasty, or nowadays they have the one Korean doctor. He used the radiofrequency to treat the conjunctival callosis also. You can see after 16 times, the degree of the conjunctival callosis have been better, reduced. I think there's something help. They chinked the abdominal vessel. Sometimes the collagen underneath the conjunctiva have been better. After 22 times, you see the conjunctival callosis have been gone without the surgery, and she has no more dry eye. The dry eye have been improved so much. In my practice nowadays, if you have the significant dry eye patient, a new one, if you do the IPL for one time, I would say 10 to 20, 15% improve in one time. If you about 5 times, improve about 40, 50% for the overall discomfort. But you need the medical, topical medication and the systemic medication maximally also. But if you do about 8 or 12 times, it can improve about 80 to 90%, but not 100. After that, you need maintenance every 3 to 6 months. For maintenance, to my practice, it's forever. Toyo also said like that. Long-term effect. This is a good paper about the long-term effect from China. They talk about the treatment like this for 9-month follow-up. All of the patients check pre-op and post-op is so fine. Everything is all right. So the conclusion, IPL improved the meibomian gland secretion after 6 months after the treatment. And safety of the IPL. This is a good paper again from China. They collect the case about 2,282 cases. The side effect from the IPL only 3.2%, and the side effect is so minor, like epidemic keratoconjunctivitis, herpes, simplex. In the herpes case, if you take the history and have the herpes from the simplex or zoster, please do not try to do that, or you need to give the antivirus before. Further, and uveitis and dermatocyclitis, that's one for each. So the side effect is minor and treatable, and no serious side effect. For the therapeutic efficacy, that's another treatment that this is a good paper from Japan. Dr. Arita published this one. This is a good paper that let me dare enough to start to do more than 8, because she said she do about 8 treatment and follow up, about 1 follow up, 2 follow up, and final follow up at 32 weeks. All is safe. So at that moment, I do about 4, I do about 8. Oh, that's fine. So I dare enough to do more. Now you see, I do about 32 and still all right. But they have the trick to, you have to need the metal contact lens to put inside, inside to protect. And what are the future of the IPL treatment? We talk about the safety, we talk about the how many times, and we talk about how to exam and how to wrap. This is a critical point. If you are the ophthalmologist and you want to be the best surgeon, you treat your surgical case and they have pre or post problem of the dry eye or ocular surface problem, you treat this one, you use this one. You use the concept of the demodic level or not. You use a mucocutaneous junction for improvement. You can see before the IPL, after 20 times, the improvement gonna be the characteristic of the improvement gonna be the reducing of the telangiectasia, start from outside to inside, start from inner to inside. I have found this is a characteristic of the improvement, but I still cannot answer you why it is. But in the world, everything have the answer, right? But I do not know now. So maybe in the next 5-10 years, I can tell you, or someone in the US, someone in Japan, or you can tell me, or someone in China can tell us. But this is really fun to learn and to figure out about this one. And you see about the degree of the hyperkeratinization. They have been reduced and softened. When you extract this one, nothing come out. When you do IPL, this one, when you extract the gland, the content come out. What the benefit for the content come out? When the patient you examine the patient with the dry eye, you check the cornea is so clear, but the patient always complain about discomfort around the eye. That's very common, because when you examine the patient in the outpatient, I think 75 to 85% of the outpatient, when we are the resident, we are the general ophthalmologist, they have the dry eye. But the problem is most of them under diagnosis and under treatment. So nowadays, I think we have the good weapon. It's a very good opportunity for us to improve it. And nowadays, if this patient, she is 80 years old, but she had the problem. Good question. Why don't we treat this lady since she was 20 or 30? If we treat this one when she was 30 or 30, when she was 80, she's gonna not have something like this, like a degenerative disease. So I think nowadays the dry eye gonna be treatable, preventable, and it's can be treated. In the China, you know, how many years that they start to do the IPL? You know, can you guess? In China,
40.
after 10 years, after 10 years, they do IPL for the dry eye. Because if you have the patient like a teenager, 10 years old, 15 years old, with the problem of bling like that, in the old day we said, oh, this one is a psychic trauma. They call fix. You go, no ophthalmologist, you go to see the psychologist. No, if you take a look on the ocular surface properly, you're going to see they have the abnormal ocular surface inflammation. They have the really, we call pediatric meibomian gland dysfunction. If you do the mammography, sometimes 10 years old, the gland loss 70%, 80%. I have seen one of my son friends, 10 years old, they lost about 90% of the meibomian gland in 10 years old kid. So, and they have a lot of allergy. So they have the really bad. So I think nowadays, if we treat this one, you can check about the size of the abnormal blood vessel, MC junction, the recovery of the pink area, and the meibomian orifice, and the vessel side, and the demodex and the bacteria. That's a good criteria.
Okay. Today we can
the protocol nowadays. This is the last slide. The protocol nowadays in the conventional. The first IPL they do cheek to cheek for 2 passes. This is a conventional that Toyos create this one and use around the world. And the second one have been modified by Laura Perrinan. She applied the first protocol by cheek to cheek for 2 passes, and she applied upper and lower eyelid, 3 to 4 shots, the upper and lower eyelid for another 2 passes. So totally about 70 shots per one treatment, and it's last about 5 minutes to do that. After that, you do the eyelid, meibum expression, or we call in Thailand eyelid spar. I term eyelid spar because initially I have no idea what we should call. Do you have eyelid spar in Japan? Because the patient, I would try to use this word because the patient may feel good when they go to spa, and the feeling is something like to go to the spa, really. Because I got this one, when I got the spa, the gland have been expanded. The level, if you have the cicatricial entropia, because of the gland have been dilated and blocked, so they drag the posterior lid margin, they have the vertical contraction. They move the eyelid from normal position to backward. Once you do the myboom expression, if you observe some degree of the entropion have been improved a little bit. If we have the patient that have this one and we do like this, when they watch young sometimes, I think the entropion could be prevented also. And the modified treatment is by 1 and 2, and we do 4, 8 or 12 times. It's the first line of the treatment. And after that, every 2 to 4 weeks. And that repeat every 3 to 6 months. And until you satisfy, something like that. And that's by conclusion. IPL is my new favorite and primary treatment for anterior and posterior blepharitis. And after follow the these two guidelines have helped me to manage a complicated Epiphora efficiently. And the patient with the nasolacrimal duct obstruction need to be informed, or all patients that we do the surgery need to be informed about the problem of the blepharitis initially. Because if we don't do like that, in US they have the good paper talk about the cataract surgery. If you have the significant MGD with the significant cataract and you do not treat the MGD first and you go to cataract surgery, 30% of the case have the more dryness and they're gonna be last about 6 months. We always talk that if we do not inform the patient first about this one, everything happen after surgery gonna be the complication from the surgery. That's the way it is. So that's all my talk. Okay, hopefully the time more than Tommy expected. I'm sorry about that.
It's okay.
Right. Okay. Any of our colleague? Any question, please? This is just my experience, short experience to share. But I think maybe right, maybe wrong. But I think this one is pretty new, and when I focus on this one, the bad part is my surgical volume reduced significantly, because before I gonna perform any surgery, I precisely adjust the patient more precisely, because I don't want any complication in my practice, because I want everything in my hand 100%, but that's difficult, but I have to choose the patient. Nowadays I do surgery without notice this one. It's easy, but when they have the problem come, it's difficult to deal. So if our colleague interested in this field, I think this one is another important subspecialty. They're very difficult to treat and make a lot of job to do. And you're gonna be, if you focus in this one, you keep in mind you're gonna be very busy and very tired. Yeah. Any question, please?
Yeah. Thank you for very informative and encouraging lecture. So, is there anyone? Yeah.
Hi.
Thank you. Thank you for
Nice to meet you.
Nice to see you again. I have one question. Do you have any recognized physical change or tissue change after meibomian gland dysfunction treatment, including IPL and Demodex removal? Do you have any tightening of trousers or eyelids?
You mean for the tearing problem or irritation, epiphora, like that,
Yeah.
right? Honestly, in the old day, I used to think like that. I used to think like in the literature that they talk about if you have functional epiphora or pseudo epiphora, you just do tightening lid.
Yeah.
And you do the conjugal callousy correction, or you do the little inversion, something like that. Nowadays, I do not believe. But in the old days, I used to think like that because I did not extend the patient in depth. I did not use a good microscope to see microkeratitis. I did not have the micrography. So I cannot answer why the patient have the tearing. But nowadays I have a good machine enough to explain the patient why the ocular surface have the significant information why the tearing happened. So I correct every cause of the problem correctly, properly. When in my experience, in my practice, when I correct everything according to the cause, it could correct the tearing, and the tearing is all gone. Yeah, totally. No need to do the lid tightening. If you do the lid tightening, it may improve about a couple weeks, and then it come back again. 15 years ago, a good case. I have no concept about this one. One of the really VIP politician in Thailand. He has a 75 years old. He had a very dry eye, a tearing problem. A previous mentor in medical school do the punctoplasty, punctodilatation, punctoplasty, and put drops and no improvement. He came to me and he had a significant conjunctival. I did the 360-degree conjunctivalplasty from grade 4 from conjunctivalplasty to be really smooth like young adult. Yeah. After that, I used fluoroquinolone for a while and drop. He improved about 1 month. After that, he come back again. When I thought this one, I have no answer for him. So I said, oh, that's not my job. My conjunctivalplasty is good. So you go to see dry eye doctor, cornea doctor. That's the way it is. So I cannot explain. So if retrospectively I go to the time machine back, I will bring him to do the IPL. Yeah.
Or one more thing, is there any effect to removal or killing the Demodex by IPL?
Yes.
Is
Yes.
it-
I think it's faster. Because when you do the IPL, the temperature is about 56, 58 Celsius. It disturbs about the cell wall of the Demodex. The heat disturbs about the fluid inside. They like you have the bomb and you have weak about 50%, but you lie down on the floor and but you're not die yet. Yeah. So if you stop that one may lay the egg for 30 eggs a day. They cannot recover. So after IPL, you need to do the very good lid hygiene by microscopic. By general like this, you do the only outside, not inner side. Not because the eyelashes they have outer row, middle row, and inner row. Most of us did not concern about the super inner row of the eyelashes, because if you have 1 or 2 Demodex, they lay the egg 30 eggs a day, and if you left one body and you left for months, they come back. Yeah. But if in IPL for a couple of times, if you do very good one with the 3T oil and the solution, some patient can eradicate 100% and dramatically improvement. Yeah.
But there is no side effect to bulb over hair.
No. Yeah, but if you do the IPL more than 2 millimeter from the eyelashes, no problem. If you do nearly more than 2, eyelash will lost. One of my fellow, he did the IPL, not careful. The eyelash lost about one third of it.
Yeah, I was going to ask actually about the eyelashes loss. It might be a good thing, especially for the patients who have distichiatic eyelashes, because they, I can tarsal fracture them. Looks great, 1 month, 3 months, they'll come back again. A new row of eyelashes is actually growing. So I don't know, this might be one of those things where, even if the eyelashes are lost, is good. It's a good kind of loss, and the patient is at the end of the day, he still benefits. And I have patients that just telling me, doc, just cut away all the eyelashes because they just keep coming.
Oh, that's a wonderful question. If you have the cicatricial entropion,
Because it's coming from this.
right.
Yeah.
In the old day, when I was young, when I was a beginner, sometimes I pull up and I cautery that, and
No,
it come back.
Yeah, your posterior lamella shrinks, and
exactly.
actually just makes it worse.
Nowadays, if I have the more than 5 or 7 lashes, I encourage the patient to do total tarsal rotation, not fracture. If you do the total tarsal rotation, you use microscopic lithotomy. It's much better than the loop. You can see everything. You cut about horizontal cut about 1 millimeter above the lid margin, but you see the point of the maximal contraction of the posterior lid margin and cut it in full thickness. And you dissect underneath in the back of the tarsal plate, right, and go underneath and separate about tarsal plate and orbicularis, and you do the modified V procedure, use a 6OYQ suture and outside and maximally outside, and you do the oral doxycycline or oral azithromycin many months after that, and you do the IPL before and after that. I think this one can make dramatically improve that and prevent that the recurrence.
Maybe you let me know. Yeah, because I don't have the ability to buy the IPL machine at my eye center yet.
You know,
Yeah.
if you invest in this one, if you invest in the IPL within 6 months or a year, the machine cost will return, and you would do this one. But the problem is the IPL is so boring, not fun like surgery, but it help patient a lot. Yeah, but it's not that fun because it's so boring, not so challenging. It may fun when you initially you try to do that one and you learn and read all that one. When you do, I have done about 350,000 shots for the past 4 years. So it's so boring, but it's good.
Thank you.
I guess.
Yeah.
Yeah, thank you very much.
Thank you, Tommy.
Yeah. Actually, I have IPL in my clinic in Gunma,
Oh.
and I have dry eye. So I'm a good candidate for them.
Right,
Yeah.
Tommy.
Yeah.
I have very bad eye also.
Yeah.
I think everyone have.
Yeah.
I have never seen anyone that not have the meibomian gland dysfunction, but some patients have the symptom. Some patients don't have the symptom. Once you have the symptom, that is beyond the compensation. Yeah, but if we can treat the patient like us since 20 or 30 early, that's like anti-aging. That because some people come with the meibomian gland loss 80%. If you are the millionaire, you cannot buy it back. Dry eye, you have money, but you cannot buy it back. But you have money to pay for the surgery, but you cannot buy the meibomian gland back.
Okay. So I know, Gok, you have many things to talk, but we need to go dinner.
Okay. Sorry
So,
for letting.
thank you for lecture. Good lecture.
Thank you very much. Thank you. Very happy to visit Oculofacial Clinic Tokyo. Tommy impressed us, and I think he showed the world that how good he can do, and he got the inspiration for us and for our young generation. Many young oculoplastic or young ophthalmologists would like to be like him. So thank you for what you have done and inspire us.
Yeah.
Thank you.
Thank you very much.